The DSM-4-TR lays out diagnostic criteria for bulimia nervosa. First, recurrent episodes of binge eating. Binge eating is characterized by a client eating in a discrete period of time, within 2 hours usually, an amount of food that's definitively larger than most people would eat during a similar period of time and under similar circumstances. Also, the client feels a sense of lack of control over their eating. They can't stop eating. They feel they can't stop eating, or they can't control how much one's eating. Also, they have recurrent inappropriate compensatory behavior in order to prevent weight gain. These are things such as induced vomiting, misuse of laxatives, misuse of diuretics, enemas, other medications, fasting, or excessive exercise. Third, the binge eating and inappropriate compensatory behaviors both occur on average at least twice a week for about 3 months. Fourth, self-evaluation is unduly influenced by body shape and weight. The difference between bulimia and anorexia, a big difference that helps with the diagnosis, is that people suffering from bulimia nervosa, they focus on their body image and their body shape, not necessarily the actual weight that they're at. And last, the disturbance does not occur exclusively during episodes of anorexia nervosa. While assessing for bulimia nervosa, it's important to use a structured interview. This is to gain knowledge of the client's weight and caloric levels, their exercise rate, such as how often, how long they exercise for, and how strenuous they exercise. Also, you'd want to gather the number of binges and purges on average, and also the types of food the client chooses to eat. It's also important to gather information on the client's ethnic, religious, or personal views. These can help in assessing whether or not the behaviors are binge eating or merely a part of the client's culture or ethnic background. Common treatment for bulimia nervosa follows the cognitive model. Step 1 of the model helps clients establish self-control over eating. This first step usually takes 2 to 4 sessions per week. Here, the dangers of purging are explained, such as torn esophagus, dependence on laxatives, chipped teeth, teeth damage, and even as serious as cardiac arrhythmias. Also during these sessions, you'll want to monitor the client's weight weekly. Have the client self-monitor, whether through a food journal, a program online, as long as they can self-monitor their food intake, what they're eating, how much they're eating. And help them establish normal food eating behaviors by restricting eating to 3 to 4 meals with 1 or 2 snacks, without skipping any meals per day. Finally, if there's failure at this stage, more serious treatment may be needed, and the patient may need to transfer to an inpatient hospital. Step 2 of the cognitive model focuses on cognitive therapy. Here, you'll focus on situations where the client loses control. You'll help them learn adaptive coping and problem-solving skills. You'll identify thoughts that interfere with change. You'll introduce forbidden foods to the client's diet. And you'll confront avoided situations. Step 3 of the cognitive model focuses on relaxing restrictive food rules and dieting for the client. You'll also consider how to avoid future lapses. There are other options available other than the cognitive model, or to be used in conjunction with the cognitive model. Some of these include peer involvement during treatment, group treatment, and longer treatment, more sessions, or inpatient therapy.